my name is Artur Kowalik. I'm a head of Department of Molecular Diagnostics in Holycross Cancer Center in Kielce in Poland. I'm also a professor of medical biology in Jan Kochanowski University. I'm going to present some data with our experience with torrent of data from NGS technology. This is my disclosure. Our department is part of the Holycross Cancer Center. This is a comprehensive center with many different clinics, including head neck surgery, radiotherapy, urology, general surgery, genetic clinic, oncohematology and bone marrow transplantation, chemotherapy, clinical oncology, and gynecology. We established Department of Molecular Diagnostics in 2018, and 3 years later, first personal genome machine arrived in our laboratory. And 3 years later, we set up as a first laboratory in Poland a diagnostic workflow for BRCA1, BRCA2 whole genes testing in Poland. 2 years later, the next system arrived in our laboratory, and we start the BRCA1, BRCA2 testing in ovarian carcinoma tissue for targeted therapy stratification. And after 2 years, we establish another workflow, myeloid oncomine myeloid panel, which is used for oncohematology disease testing. We also get another unit S5'. We do mostly panel testing. We have intensive cooperation with many institutions in Poland, also in foreign institutions outside Poland. And we are reference laboratory for one big pharma company in Poland. We do about 10,000 different kind of tests, from single gene, single mutation to gene panels, and we can divide our workflow on 3 different types. First is a predisposition, genes which predispose patient to cancer development, like BRCA1, BRCA2, tissue testing for targeted therapy in colorectal carcinoma, lung cancer, melanoma, thyroid cancer, ovarian, endometrial, and many, many other. And the third is oncohematology diagnostic, for example, for myeloid malignancies like AML. We started as usual laboratory with one mutation testing based on qPCR or Sanger sequencing. Here there are examples for BRAF testing for malignant melanoma or thyroid carcinoma. Then we develop our workflow based on NGS. Here is an example, nice example of very comprehensive testing of more than 500 samples of colorectal carcinoma, mostly testing for KRAS, NRAS, and BRAF for monoclonal antibody introduction. And the testing is fast, comprehensive. We extract information from 47 genes as well. We have very nice experience with total nucleic acid lung cancer panel. We adapted this panel also for FFP material. This panel is able to assess 12 markers. We are going to extend the testing. I will mention about this a little bit later. And mentioned earlier, BRCA1 and BRCA2 testing for PARP inhibitor stratification in ovarian carcinoma. We have very nice experience with the oncomine myeloid research assay panel. As a diagnostic test, we set up our workflow. The panel is very robust, comprehensive. You can see the many cases diagnosed with this panel, like acute myeloid leukemia, other leukemias, MDS of MPN. What are the problems in the laboratory? Of course, most problem is the quality of the DNA isolated or RNA isolated from FFP material. So the second problem is turnaround time. NGS takes about 5 days, but this is the ideal situation. Comparing to qPCR based testing, which takes only 2 days, NGS-based testing is more complicated. So we are looking for solution to be able to perform NGS in one day. So we bought as a first center in this part of Europe 1 year and ago GeneXus newer system, which is able to deliver first results in 14 hours. So the machine is very user friendly and easy to use. We are using the precision assay, which is very robust assay and includes many genes for selection patients for targeted therapy, includes NTRK1, 2, 3 genes for tissue agnostic treatment. Here an example, this is the thyroid carcinoma we were able to detect with this panel NTRK based fusion gene. And this thyroid carcinoma, this case has a poor prognosis comparing to mostly 95% of thyroid carcinoma cases with very excellent prognosis. But we were able to offer this patient targeted therapy treatment thanks to comprehensive testing. And next to the EGFR, KRAS, BRAF, and many other markers which are assessed for lung cancer treatment, here is an example of MET exon skipping mutation detected in the lung carcinoma patient. And my favorite case, here you can see colorectal carcinoma case. Please concentrate on the red frame. You can see that patient has not that tumor, we did not detect in the tumor KRAS, NRAS, and BRAF mutations. So the patient could be treated with anti-EGFR monoclonal antibodies, but we were able to detect very high copy number variation ratio for RBB2 gene, which codes for HER2 receptor. So in that context, patient would not be able to respond to the anti-EGFR treatment, but should be included in the clinical trial for the treatment in anti-HER2 uh, monoclonal antibodies on TKI inhibitors. What is very nice, uh, we asked our surgical pathology department for immunohistochemistry confirmation, and you can see on the right side very nice picture of protein overexpression. So this is once again example that the panel is very robust and uh, can comprehensively test tumor tissue. Last but not least, this is our experience with BRCA1 and BRCA2 testing. This is a comparison between Oncomine research assay versus Oncomine BRCA1 assay on JX. We observe perfect agreement between these two assays, and we tested mostly FFP material with two different types of cancers, and we also included a case from pancreatic carcinoma based on blood testing. The coverage is very nice, so it once again means that the panel works very nice and is very robust. Here are the example of detected mutation BRCA1, BRCA2 genes. And we think that using faster sequence, I mean to GeneXus, we are able to deliver to our patient results in 14 hours. So it is very important to introduce targeted therapy as soon as possible in the ovarian carcinoma treatment. And of course, it is very important to prepare the surgery for BRCA1, BRCA2 mutation carriers, because in this type of patient, the bilateral prophylactic mastectomy should be proposed to the patient instead in the patient without BRCA1, BRCA2 mutations. So between the biopsy, diagnostic biopsy, and the surgery, it's not so long time, so GeneXus could be helpful to help make decision by the surgeons. And what we are doing now, we are changing our workflow. So 90% of our NGS workload is based on 4 panels: Oncomine BRCA1 research assay, cancer panel version 2, total nucleic acid lung panel, and myeloid. So we think we will be able to exchange these panels on Oncomine BRCA1 assay GX, Oncomine precision assay, and newer panel for myeloid. Of course, we have many custom panels we are using in our diagnostic workload, so we are waiting what will be possible to do in the future. Our directions, future directions. We are going to adapt Oncomine comprehensive panel for HRD detection, which is very, very needed and important for PARP inhibitors. We have very nice experience with B cell clonality analysis. We would like to introduce this, and we created very robust panel for MRD detection in acute myeloid leukemia, which was validated against and other sequencing machines and reagents. And we are going to introduce this as this test for our patient with acute myeloid leukemia. Of course, we are preparing because we are building facility card for card treatment. We are going to use NGS based technology to assess the efficacy of this treatment to monitor minimal residual disease. Of course, we are thinking about single cell sequencing. Uh, we will see what will be possible in the future. What should be stressed that with ion tolerant Genexus systems, diagnostic is very easy to perform and very fast, which will be very important to make clinical decisions for the patient, because sometimes you do not have enough time when the material is delivered late and the clinicians asking you to be as fast as possible. So comparing to other systems in the market, it was impossible to do diagnostic in 24 hours. Now we are able to do this diagnostic. So what would be very helpful in the future to make the right decision for the patients. So I think to be fast, quick, will be very, very important in the future, because we observe there are so many drugs in the clinical trials. So the cancer treatment will be impossible to start before the diagnostic is finished. So uh, once again, Genexus would enable very fast and user-friendly workflow to be introduced for every laboratory. So what is last but not least very important, I think that the Genexus would have possibility to be upgraded to CIVDR instrument. So with what will be very important in the future, to be able to run diagnostic testing with CIDV mark. And soon it this policy will be introduced in the whole Europe. So having Genexus in the lab will be very easy to adapt to these rules. And what is most important, that comprehensive tumor testing means more treatment options for the patient. Thank you very much.